Hello, this is the last in a series of four video lectures on drugs acting on the respiratory system. The focus for this last video lecture will be on COPD management and the management of cough. When do you suppress cough? Is there actually use for mucolytics and expectorants? So first, COPD. You probably by this time have already heard of the way that we assess COPD. We use this rubric where you try to classify the stage or the step of COPD according to the presence of symptoms of breathlessness, for example, as categorized by these systems, the risk for exacerbation based on the history, and the risk for airflow limitation. A would be probably the most or the least severe of the steps of COPD. And just to then give you an idea of the goals of therapy for stable COPD, you want to reduce symptoms, and the reason why you would like that is to improve exercise tolerance, their health status, their quality of life, and reduce the risk for disease progression and exacerbations. And all this would be, of course, leading to a reduction in mortality. And the way to do all that is to then categorize the patient as to which step or group the patient falls under based on the rubric. If the patient, for example, is group A, where there are very minimal symptoms and the risk of exacerbations is low, then they can just be given any bronchodilator. They may be given just as needed or PRN bronchodilators like SABA or SAMA. While on the other hand, beginning at group B, they will be needing a long-acting bronchodilator, either a LAMA or a LABA. And for group C, typically they will need a LAMA. Once the symptoms have symptom category is higher, or the risk, for example, of exacerbations is higher, such as what you find in group D, where in fact there's also a higher risk of exacerbations, then typically they should be maintained on either a LAMA, like in group C, or a combination of LAMA and LABA, or even an ICS, inhaled glucocorticoid. So this is in fact the only group for which initial pharmacologic therapy could be a combination of LABA as well as inhaled corticosteroids. And who do you give corticosteroids? If you can read the fine print, it says you consider it if the eosinophils are more than 300. And this is a phenotype or a category of group D, which probably talks about the asthma COPD overlap. And therefore, there might be some use for the inhaled glucocorticoids. Now, whenever there is a progression in the follow-up treatment, either dyspnea is persistent or there are exacerbations, then from single drugs, single controllers, you can give them combination of controllers. And if in fact at this point there are still symptoms of dyspnea or exacerbations, you could consider switching the type of inhaler device or the specific molecules, because there are many choices for LABA, for example, or even the ultra LAMAs. And if not, here you can see that you either consider adding antibiotics or this agent called roflumilast. So we'll talk about that in a bit. The other option before going that is actually a triple combination therapy. Okay, so the controllers of choice in COPD are actually the bronchodilators, choosing between LAMA or LABA. There are actually many authors and the guidelines that prefer LAMA over LABA because there are less adverse drug reactions. And it has been seen that monotherapy with either LAMA or LABA for symptomatic patients with decreased FEV1 improves quality of life and decreases exacerbations, as well as may decrease mortality and risk for hospitalizations. The combined use of SABA as well as LAMA are actually preferred if symptoms are not improved with the single agents with monotherapy. And like I showed you already, this is in Group D or Category D of COPD. Now, with regards to other controllers, in the past we have used methylxanthines like doxophilin or even the theophylline slow release for COPD. But again, this is no longer a lot in use in COPD. Maybe it's a third-line therapy. Likewise, inhaled glucocorticoids are only added to LABA or LAMA, actually beginning at category D. So please correct this because the new GOLD guidelines already suggest using the combination of ICS plus LABA only in Group D, because this was an old slide. There's likewise no benefit for short-term oral steroid therapy. And long-term monotherapy with oral steroids are also, of course, not recommended. So what is recommended is if you're going to then start ICS at category D, is to make sure that it's combined with LABA. Now, like I told you in the rubric, when dual or even triple combination therapy have been tried and there is still a failure to decrease the symptoms, then you may try a new drug called roflumilast. Roflumilast is a phosphodiesterase 4 inhibitor that has also been shown to reduce exacerbations among people with chronic bronchitis, especially at Group D, those with severe and very severe airflow limitation. Remember that when we talked about the mechanism of action of theophylline, that is actually a phosphodiesterase inhibitor, but a non-selective one. And apparently it is PDE4 that is selectively expressed in airway smooth muscle and pro-inflammatory cells. And this has shown a lot of promise in COPD. Now, this phosphodiesterase 4 roflumilast decreases the frequency of acute exacerbations, which are associated with accelerated progression in COPD. But this airway inflammation may continue even after smoking cessation. It responds incompletely to glucocorticoids and it's neutrophil predominant. And targeting the phosphodiesterase 4 could arrest the airway remodeling. This has been found in studies to show a decrease in sputum, in neutrophils in the sputum, as well as the other cell elements like eosinophils and lymphocytes. Now, in COPD, while we talk about drugs, non-pharmacologic therapy and advice is very important. Smoking cessation is a key intervention, but reducing indoor and outdoor pollution is also a major public health priority worldwide. Exercise promotion, as much as possible, is recommended, and this is also to help to cope with the other comorbidities of COPD whenever it's possible, and that's why you would need pulmonary rehabilitation. Appropriate vaccination with flu and pneumococcal vaccines are also important because viral and bacterial infections actually trigger exacerbations in COPD. And finally, oxygen use and surgical therapy may be helpful in a highly select group of individuals to decrease mortality risk or to decrease symptom impact in COPD. So we're midway through the lecture. We will now talk about the management of cough. We frequently hear in advertisements things like this, where they say huwag pabayaan ng sipon. And the question is, how is it even possible for us not to mind actually colds, And instead of just really encouraging us to hydrate ourselves, to rest, no, whenever we have colds, no, there are frequently being pushed, no, in advertisements a lot of different drugs like antihistamines or even decongestants. And although they do have use for symptomatic treatment, the common cold, no, does not typically require any specific treatment. If this is allergic rhinitis, certainly you will need treatment. But if it's the common cold, you probably just need to rest and hydrate, and even steam inhalation to help, no, with the nasal congestion. But what we notice is that there are really very many, there's a proliferation of many cough and cold brands out there in the market. This is not even a comprehensive list because this was an old list that Dr. Rahao compiled over the years that we've been lecturing this. And if you take a look at, for example, the total market share 10 years ago of all the drugs that have ever been bought in the Philippines, you can see that the market share for Ventolin, and this is salbutamol actually, runs up to more than a million. Is that a million? And for example, common drugs like Neozep, which is just paracetamol and phenylephrine, or Solmux, no, which is carbocysteine, are also a big chunk of the total market share for these drugs. And so we need to talk about cough because you will encounter a lot of this, of course, in your practice as general practitioners, no? And patients will come to you asking for treatment of cough. And so we need to find out which kinds of cough, no, would you need suppressants. And is there any use, in fact, for mucolytics and expectorants? So we need to realize that in the treatment of cough, there are actually several kinds of agents. No, you have first the so-called mucoregulators. Realizing that in certain disease conditions like chronic bronchitis, even cystic fibrosis, and certain people with severe asthma, mucus hypersecretion may be a problem. And this poses a problem in terms of frequent coughing, frequent clearing of the throat, some difficulty of breathing because of the inability to bring out the sputum or the mucus. This is especially true for cystic fibrosis as well as chronic bronchitis, for example, where in chronic bronchitis, the hypersecretion is due to the chronic irritation by cigarette smoke. And of course, the action of the enzymes coming from the neutrophils, which have powerful effects on mucus secretion. No? Even mast cell-derived kinase is also a potent mucus secretagogue. So there's a clear rationale for why we would like to actually get rid of mucus. And so we are searching for evidence as to which of the different kinds of mucoregulators actually have any evidence of efficacy. And we have two sorts of mucoregulators, the mucolytics as well as the expectorants. So the mucolytics actually decrease the sputum viscosity. They are typically derivatives of cysteine, and many of these mucolytics reduce the disulfide bridges that bind the glycoproteins and the sputum that make it stick, no, to the airway, and that bind the glycoproteins to other proteins such as albumin. Some mucolytics also act as antioxidants, and providing these agents, therefore, could help alleviate airway inflammation. They're typically also well tolerated without any much adverse drug reactions. They're orally available and they're typically over the counter, but many of them have actually are really of little clinical benefit in many different acute respiratory conditions. Now, among the different agents, it's actually N-acetylcysteine. This is a drug that's also available as an inhalational agent or even an IM and IB form that is typically used in certain cases of poisoning. But what we're talking about here is the N-acetylcysteine that is in an oral formulation, typically a tablet or a tablet that can be dissolved in water or juice and taken orally. The other kinds of mucolytics are ambroxol and carbocysteine. So, like I said, typically these mucolytics, if you just have an acute respiratory condition, you don't need it. You just need to take a lot of water, probably steam inhalation. But for certain disease conditions like cystic fibrosis or even chronic bronchitis, which of these mucolytics have the evidence to support their use? And it appears that among these drugs, no, for many of them, they're really quite disappointing. But there is some evidence for N-acetylcysteine. It appears to decrease the number or the frequency of exacerbations and the frequency of hospitalizations among persons with COPD and improves pulmonary function symptoms and quality of life when given over a 3 to 6 month period. So what I'm trying to say is that if you are going to use any of these drugs at all, the one with the most evidence for efficacy is N-acetylcysteine, especially when used for persons with COPD. There's another drug that's actually also available in the market. It's called Mesna. This is a mucolytic that is actually put in endotracheal tubes, or for among those with tracheostomy, and this is to allow greater mucus mobilization for suctioning among those who are intubated, either in endotracheal tube or those who are on tracheostomy. So that's that for the mucolytics, no? So the best kind of mucolytic, if you're going to give anything at all, is N-acetylcysteine. How about Lagundi? There's actually also some benefit of efficacy of Lagundi. However, it's never been tried among pregnant women, so please do not use it. The evidence, though, is mostly for acute respiratory conditions rather than asthma or COPD. Now, how about the expectorants? Expectorants are drugs that enhance the clearance of mucus when administered orally. They're commonly prescribed, but many of them are so-called throwaway drugs. They have little evidence for efficacy. And they're often derived from emetics like ipecac, for example, or guaifenesin. And on the other hand, adequate hydration, taking a lot of water, steam inhalation may have similar outcomes. So again, if you're going to use anything for persons with problems of increased mucus production, there is some evidence for N-acetylcysteine in terms of clinical outcomes. And second to that probably would be Lagundi. So again, many of the current therapies for mucus hypersecretion are of limited use. There's a paucity of information on many other potential therapies. Data from small animal models also cloud the interpretation. So at the moment, we only really just advocate N-acetylcysteine and probably Lagundi. Now, we need to go back to what we know about the cough and the mechanism of cough to be able to find out how to suppress it. So cough is, as you know, a protective reflex that allows the removal of foreign material and secretions from the airways, the bronchi and the bronchioles. It's a common symptom, and therefore before treatment with antitussives, you need to identify the underlying cause that may require therapy, because cough is a protective reflex. And so when should you suppress cough? We typically should suppress it in the dry, painful cough of neoplasia or cancers in the lung, or even pleural diseases, neoplasia as well as pleural diseases. So it's an ineffective, irritative cough that is ineffectual, and so this leads to poor quality of life, and therefore in order to allow patients, for example, to rest, to sleep, then cough has to be suppressed. Also, the irritative cough in inflammation of the respiratory tract, the so-called post-inflammatory coughing after an epiglottitis, that needs to be suppressed. Sometimes we get severe viral some viral infections, upper tract infections, We actually already recover from the viral infection, but there is still some inflammation that remains, and we keep on coughing because of that. Maybe that cough needs to be suppressed. And of course, in hemoptysis, when we're coughing out blood, you need to suppress it, no? In order for, in fact, the bleeding to actually stop. And so there are also some indications of what should not be suppressed. You shouldn't suppress cough in bacterial lung infections, in asthma, in bronchiectasis, or even chronic bronchitis, because you need to be able to put out the mucus, no? And giving antitussives, some antitussives, for example, in chronic bronchitis, can actually cause harmful sputum thickening, retention, and even secondary infection. So do not suppress cough in these situations. So what do we have as choices for antitussives, no? There are two main kinds of antitussives, but many of them are actually centrally acting. They decrease the sensitivity of the cough center in the medulla to peripheral stimuli. And these antitussive agents do not actually influence the underlying condition. Like if it's a neoplasm or there's pleural effusion, it just needs to be drained. And so this really just suppresses the symptom of cough, typically through a central mechanism. So two main mechanisms of action, central as well as a peripheral action. The greater majority just have a central mechanism of action. And foremost among these are the opiates, or the naturally derived opioid analgesics. The prototype is codeine. And even if it's an opiate, it has a less addiction potential compared to the rest, like morphine. They're effective cough suppressants, but like other opiates, the main side effect could be a decrease in the secretion and a thickening of the sputum. There's an inhibition also of ciliary activity, and thus there may be a reduction in the clearance of the thickened sputum. It also leads, of course, to constipation because of the slowing down of the gastrointestinal motility. And codeine is the prototype, but morphine may also be given among those with intractable cough from bronchial carcinomas. The next drug is dextromethorphan. And if you know about dextromethorphan, you're probably our age group, no? Because this used to be a popular over-the-counter drug. It was called Vicks Formula 4440. People loved it. It tasted very nice, no? It has a nice, sweet menthol flavor. But in fact, it was a synthetic narcotic analgesic, no? And although it has no addiction potential, its antitussive potency is apparently equivalent to codeine, with less constipation and inhibition of mucociliary clearance. So although in the past dextromethorphan was actually over the counter, now it's not. It's a regulated drug. The third drug is something that you know, no? You hear about it on radio or even on TV, butamirate citrate. The brand name is Sinicod. It's actually not a very potent antitussive. It's a centrally acting antitussive, but it's neither chemically nor pharmacologically related to opioids or opiates, and has no addiction potential. Finally, the only drug that is not centrally acting, that's actually peripherally acting, is the non-opioid drug called levothyroxine or Levopron. It has a peripheral action by inhibiting the afferent pathways that generate the cough reflex, by inhibiting the release of neuropeptides from the airway sensory nerves, particularly from the C fibers. So you've learned about two different approaches to cough, no? You've learned about the mucoregulators, the mucolytics, as well as the expectorants, and we learned that among the mucolytics, there may be some use, no, for those with problems of increased mucus production and expectoration. But the most useful among the mucolytics is probably N-acetylcysteine. and all of the expectorants do not really have any strong evidence. We also learned about when to suppress cough and when not to suppress cough. And we talked about briefly the mechanisms of action of the different drugs, saying that out of the 4 of them, 3 are actually centrally acting, and the 4th is peripherally acting through modulation of C fiber activity. So in summary, from the first video lecture all the way down to this last lecture, we had talked about the drugs for the management of asthma and COPD. And in this last video lecture, we also talked about the drugs for the relief of cough and increased mucus production. So with that, I hope